Some of these slides, when I was working on this, I'd borrow some of these slides from my mentor, Dr. Mullins. Um, so let's just go over a few things in terms of what were some of the things that we've been able to accomplish in the last 50 years in interventional cardiology for congenital heart disease. Obviously, there are some unrepaired lesions that are obstructive in nature, coarctations, all the valve stenoses, branch stenosis. Those are the main ones. Of course, this is not an exhaustive list. There are shunt lesions that we close, including the ductus, the AST, all the different septal defects. There are also a lot of the post-operative lesions, including recoarctation, branch stenosis from all kinds of surgeries involving the pulmonary arteries and the conotruncal type defects. Remember the old mustard stenting baffles where there's obstruction. There's also venous obstructions that we find. It's both systemic and pulmonary veins that we have to intervene on. Then we have all these single ventricle patients who've had Fontans and the pathway to the Fontan. So all these caval pulmonary connections, like the glens, can also become stenotic. That needs to be opened up. We also close a lot of the leaks and the fenestrations in the Fontans, the veno-venous collaterals, the systemic pulmonary collaterals, and all kinds of various lesions in the coronary and pulmonary AV malformations. So I want to go over the last 50 years. That spans from the 60s to the current time in terms of what we've done. Now, remember back in the old days, and some of us were probably within that era, it was a single plane system, a fixed X-ray tube. In order to angulate, you have to put a wedge into the patient to angle the body rather than using the cameras. Of course, over time, we developed the image intensifiers. At that time, that was new technology where you can minimize the radiation and magnify it and intensify it so you can see it better with less radiation. At that time, there were no monitors. You actually had to look into almost the oscilloscope to look into the radiation. Of course, when Cindy angiography came along with the those plates that you can run, and then the 35 millimeters, that became the next big thing. Wow, we can actually see movies now. Obviously, at that time, catheterization was restricted to only diagnostic procedures. Vascular access was obtained by cut downs at that time, mostly through the brachial vessels. There was no such thing as power injectors at that time, and when that came along, people were able to inject a big volume with high pressure, high flow to actually get some really good pictures. Of course, you had no echo, MRI, or CT to help you. So again, we've gone through a lot of advance over this time. This is my mentor, Dr. Mullins, in 1961. He looks so young. This is what it looks like 50 years later. No hair, but a big beard. He's like my father. Back in 1955, this is what Texas Children's Hospital looked like. You can see that the tables didn't move a whole lot, and then when the camera came in, you see the baby would have to have wedges to rotate to get the pictures. In 1962, when the new Cath lab came along, you see that the image intensifier came along right over here. It's at that time a single plane only. And again, not a lot of rotation, but this was the new thing at this time. And then in '69, this is actually, I don't know if some of you guys may have visited Texas Children. This is Seal. She's retired now, but she was there for almost 50 years. In '71, the next generation of lab came along. You can see the improvement. Now they actually have a camera here running a 35 millimeter frame, so you can actually see movies. Of course, when the light had to be split between the monitor and the movies, you had less, so you had to increase the radiation. 2000, the next generation, you have biplane system, a lot of moving parts, and a much more advanced system. So let's just go back a little bit. There are two major categories of interventions, right? We either open things or we close things. So in 1953, a wire pulmonary valvotomy was first reported by Rubio Alvarez. So that was before I was born. Doder and Judkins in '64 started dilating vessels in a peripheral vascular disease using just basically dilators. And they thought that was a reasonable way to go, using cut-down approach. '66, you guys all know Dr. Rashkin. He created the septostomy for the transposition, and that's when the beginning of pediatric interventions came along. So this is Doder, this is Judkins, and here's Dr. Rashkin. Now, the Rashkin septostomy balloon came out in 1966, and that was the first intracardiac, first pediatric intervention that was developed for detransposition. This is used around the world now, right? It basically improved the mixing at the HO level, as well as some of the obstructive lesions, like triatresia, sometimes may need it. This procedure pretty much has not changed since 1966. Here's the original balloon on a 6 French. Now you have the new med balloons that can go down to 5 French. But the procedure is pretty much the same in the entire 50 years that we've had it. This is what it looks like, you know, a strong but short distance jerk. We don't do this much in the Cath lab anymore. We do it with echo machines, but pretty much the same procedures back in 1966. Now, Sang Park, I believe he's Korean actually, who was from Texas, developed the Park blade. So after the septostomy came along, he came up with, in 1975, the Park blade, which we used for many, many years. I don't know how many of you guys still use it. We still have it in our lab, but I probably last time used it was maybe 5 years ago. But we still keep it just in case. You never know. So this is what the blades look like. And of course, nowadays we do transeptal punctures to access the left heart very frequently now, right? So in the last 30 years, you have pulmonary vein left atrial interventions in the adult world, EP ablations using transeptal punctures. The septostomy can create an atrial pop-off for primary pulmonary hypertension. We access the left ventricle in the presence of prosthetic mechanical valves, especially in the aorta. So you don't want to cross the mechanical aortic valve. You're going to go transeptal into the left heart that way. And of course, we do Fontan fenestrations now. In 2000, Dr. El Said actually wrote a paper on 18 years experience of this transeptal punctures through all kinds of baffles, native tissues, conduits, and intra-atrial patches, reporting success, and that they pretty much close up after the procedure. So here's an example of patients with Fontan and protein-losing enteropathy. This patient actually had a fenestration, and because it wasn't inadequate, you can see how the blade can be used. And it always scares me every time I pull this, but at some point, watch it pop. You pull and you just hold it, and you just keep pulling, and eventually it pops down. You just wait for right there. And you do this several times and using different angles. So here you see the first time the blade is facing leftward, posterior, and the second time it's anterior. So you actually cut in different directions to create a stellate cut so that the hole can be truly bigger, and then you balloon it afterwards. So this is what it looks like afterwards. See, the problem with that is that it's not very controlled. You don't really know how big of a hole you create. So sometimes it could be too big. So let's just go over the transeptal technique. And this is something that Dr. Mullins had really pretty much mastered. When I was training, the first-year fellow all had to learn how to do this. So the second-year fellow had to teach the first-year fellow how to do a transeptal punction. And we didn't have echo to guide us. So the first step is you bring it down the SVC, climb over the limbus, find the fossa ovalis. They'll just dip down into that fossa, and then you stick your needle in, you stick some contrast in there to stain the atrial wall here, and then you push hard posteriorly and leftward, and once you're in, you'll see the left atrial pressure come up, and you know that you're in left atrium. You take a little picture, and then you advance your dilator and your sheath over that, and then you go ahead and do the left ventricle angiogram. You can also take a tip deflector, tip it up to the aorta, and shoot the aortogram. Back in those days, Dr. Mullins, if you were to go retrograde, you would have to justify why you did it. In other words, your first option, it was transeptal. So we got very comfortable with this procedure. Now I know the adult world use it all the time using echo, and we always wonder why they need the echo machine for that. But obviously, if you don't do it frequently, you really want some extra imaging help. So again, in the days when we have the mustards where there's obstruction, the transeptal procedure is not as simple as going through the native septum. So just an example to show you that this patient has both an SVC obstruction as well as a pulmonary vein baffle, a pulmonary venous baffle obstruction. So you see that the transeptal puncture is actually not to the left, it's to the right, and instead of going posterior, it's going anterior. Again, that's very common in mustard baffle. So you have to know your anatomy before you stick that needle up there. So this is where we went going, and basically the wire has to go around and get to the pulmonary vein. So the sheath is now through that mustard baffle into the pulmonary venous atrium, and now you can get your wire through the pulmonary vein stenosis there. You see the baffle stenosis. Of course, that area is also next to the SVC baffle, so you have to make sure you stent both. So eventually we end up putting a stent in the SVC and then a stent in the pulmonary vein. So you see that there's both SVC baffle and pulmonary venous obstruction. They're right next to each other, so you have to take care of both. Otherwise, one will compress the other. So you can see how this is the combination of the stenosis, and this is what it looks like afterwards. Here's the of the SVC stenosis, and here's the pulmonary venous baffle obstruction. So let's go to the Fontan now. You guys are all familiar with the Fontan concept, and basically a cable pulmonary connection without a pumping chamber. The latest iteration of the surgical creation of the Fontan is the extracardiac conduit. Now that makes it a lot harder for us to do transeptal punctures because this is a conduit instead of inside native tissue. So the Fontan fenestration, as you guys know, is to give a pop-off so that blood can get to the left heart rather than go through the lungs if there's an issue with any obstruction or pulmonary vascular disease or just early post-op issues. So Nancy Bridges proposed this concept in 1990, and it was used very widely in Boston and spread around the country and also to the world. However, with the extracardiac conduit, you can imagine trying to go through that conduit is not so simple. Now, if there was a fenestration, you need to increase it. In the 1990s, using a stent to create that fenestration has taken place. You can see how that, with this situation, you can put a stent into the Fontan to create that opening and not just use a balloon or angioplasty. However, with the Fontan, with the extracardiac conduit, it gets really hard, especially if you already have stents inside the Fontan conduit. So Dr. Di Giovanni, I give him credit for coming up with sort of another transeptal puncture. It's really not septum, it's really the roof of the floor of the pulmonary artery to the roof of the left atrium. So it's really not across the atrial septum. He reported this in 2008. So you see how we're coming from the neck, from the internal jugular, coming down into the gland, and you're poking into the roof of the floor of the left pulmonary artery into the roof of the left atrium. You can see how we just basically slowly, eventually getting in there, and then you balloon it, and you put a stent in there. And so you can create a fenestration that way too. So this is in the category of transeptal punctures. Let's go to closing procedures, PDAs. You guys are all very familiar with that. This was first surgically ligated in 1939 by Dr. Gross and Hubbard. The first interventional procedure took place in '67 by Dr. Portsman in a 17-year-old. However, this required a 24 French system, so it's not a small system. It's only for older patients at that time. So let's go through some of the early developments. Since 1967, multiple devices have been developed for PDA closures. Terry King came up with the device. Then Rashkin came up with the Rashkin PDA device that has hooks on it. I'll show you examples of that. And then the Rashkin umbrella device. Chuck Mullins, as I mentioned, created the long sheath to actually deliver some of the devices. Dr. Rashkin came up with a double umbrella system, and then the double umbrella Rashkin device, and so forth. In fact, in 1987, the double umbrella Rashkin device became approved. So this is the PDA device in 1975. You can see how it's almost like a plug on one side and an umbrella on the other side. The Rashkin device in 1979 has a hook on it, almost like a fish hook that you hook onto the tissue so it doesn't come off. And he reported in one patient, and this is what that looks like. It may be hard to see, but you can see that this has a single umbrella, and there are hooks in this region that keeps it in the tissue. The double umbrella device came along in 1981, and as we mentioned, became approved in Europe and also in 1988 by the FDA. More importantly, the coil came into use in 1992. Now, I remember I was a fellow at that time, and it was a great new thing at that time, because the coils were developed in 1975 by Gian Turco for vascular occlusions. But Dr. Moore in San Diego came up with the idea of using that for PDAs. And again, I think many of us still use it to this day. Since then, many techniques were used to deliver the coil, including detachable coils. We'll talk about the Grifka sac, and then finally the Angioplasty device, which you guys are all familiar with. So here are some of the coils. It's made out of stainless steel. It's got Dacron fibers. Now the metal has been changed to that it's MRI compatible. So this is just a quick delivery technique where you basically take the picture, you deliver the coil in the pulmonary artery, and freehand deliver it across the ductus, release it in the aorta, and see how you can close the PDA. Many modifications were developed since then, including a controlled delivery system using a snare technique, using the bioptome. Of course, the detachable coils became available by J&J. And then the larger gauge coils, the 052 coils, came along. Then we have the MRI safe coils, and the NITOCLUDE was approved in 2014. You guys are familiar with the Angioplasty device that came along in the year 2000. Dr. Masora in Europe first reported this in 24 patients. It goes through a 6 French system. Excellent use. In 2003, the FDA approved it. Dr. Pass did a multi-institutional trial showing that it was pretty successful, very safe, very little major app complications, and 100% effective even a year out. You don't have to see much of this because I know you guys are familiar with this. So here's the coils, here's the Angioplasty. I don't know if you guys remember the Gian Turco Grifka sac. That came along, but no longer used because the Angioplasty device has become so popular and so much easier to use that that device is no longer used, even though it's approved. I still have a few, and one of these days I'm going to sell it on eBay as an antique. Now, of course, in the ADO2 device came along in 2014. You see the difference. They made it smaller delivery system and much easier to use in smaller children. So here are some of the Angioplasty occluders, the different generations. That's the original one, the ADO in 2003, the ADO2 became approved in 2014, and then the ADO2 additional size, or AS, that's available in Europe but still not available in the US. Let's talk about angioplasties. Grunzig first came up with this idea in 1974. He was a radiologist, actually, using balloons to dilate stenotic vessels. It became available commercially in larger balloons, and that became a huge area of procedure for many interventions in both adult and pediatric interventions for all kinds of vascular diseases. Through the early and mid-'80s, here's a bunch of papers from various pediatric cardiologists talking about angioplasty in various places. Singer in coarctation, Dave Driscoll for the pulmonary veins, Gene Kahn in pulmonary valves, Jim Locke for coarctations, Finley for native coarctations, Jim Locke in the branch pulmonary arteries, Lababidi for aortic valves, Jim Locke for the venous channels, including the mustard baffles. Alan Cribier was the first reported use in the elderly, especially in the aorta. Of course, because of calcifications then at that time, embolic events took place. So in the early 80s, the balloons were all in the 9 French system. Now that's very big by our current standards, but that's all they had. I remember when I was training, we routinely used 9 French. We had a rule of 7. 7 years old, anybody less than that, 7 French was what we used. Of course, now we go to much smaller sizes. The VACA registry, you guys must have read some of these papers, was formed to evaluate outcomes and procedures in congenital heart disease. They wrote a lot of papers in the mid-'80s to the '90s and collected data from multiple sites looking at different places. So you can see that some of the papers published in 1990, the use of angioplasty for the pulmonary valve, aortic valve, branch pulmonary arteries, native coarctations, recoarctations, and different lesions. We oftentimes will still reference these papers when we talk about our new papers and how these is the history of where we started off with angioplasties. The consensus from the VACA registry basically says that angioplasty is safe and somewhat effective in pulmonary valves, in aortic valves, in branch pulmonary arteries, and all the different valves. And basically in the current era, it is the standard of care now. We don't go to surgery for all of these lesions as the first choice. Of course, as the balloons and sheaths were improved, the balloons became smoother, lower profile, shorter shoulders. There are new shapes, and I'll show you some of them, higher pressures, even cutting balloons. So now, some of the sheaths we have go down to as small as 3 French. Remember, we started at 9 French. Now we're down to 3 French that can be used in the very small babies. Wide range of balloons from 3 to 24 millimeters, even bigger now. I've seen up to 30 or 40 millimeter balloons. Cutting balloons, little blades along the blade that can help you cut high resistant lesions to score it. You have high pressure balloons made out of Kevlar, right? The cleverest material that are bulletproof that people use to make bulletproof vests. So very high pressure. You have balloon-in-balloon technology where you inflate the inner balloon and followed by the outer balloon. The reason for that is that you can help to even out the edges of the stent as you inflate them to minimize foreshortening. You also have very novel shaped balloons, the Inoue balloon from Japan, and then the nucleus balloon that can be placed around mitral valves and aortic valves to keep the balloon stable. So you can now, all the 4 valves can be ballooned, right? We started with the pulmonary aorta, now we balloon tricuspids as well as mitrals. RV pacing started. Now, I know the adults use this as standard now, but this started in 1998 when I was a junior attending. This is one of the earlier cases where we put a pacing catheter. I give credit to my EP colleague at that time. Adenosine was used to slow down the heart rate, and my EP doctor said, well, why don't you just pace it? And we thought, that's a great idea, so we started doing it. So this was started in 1998, but now it's basically used all over the world for TAVRs in the adult world. Most people don't know that it came from a pediatric cardiologist. So just to show you the pacing, we would do a transeptal, and we left the catheter in the left ventricle to see what the pressures are. And we basically paced it so fast that we reduced the LV pressure by about half. And that was what we knew that we needed in order to make the balloon stable. So this is the result of that after that dilation. The angioplasty extends to all the other vessels now, right? We talked about pulmonary arteries, systemic veins, systemic arteries, all the different surgical shunts and baffles, and even the atrial septum. In the early 80s, the stents came along, the emergence of stents. Now, Dr. Mullins told me that in 1985, he gave a lecture called The Future of Cardiac Catheterization at the American Academy of Pediatrics, and he talked about stents. It wasn't there yet, but he was talking about it, and this was his drawing of the stent, what it would look like. At that time, people thought about using sort of wires that can be compressed, passed through the tube, and expanded. Julio Palmaz actually came up with the idea in '86, and he started putting them in animal models. Of course, that then went into all kinds of coronary interventions. Chuck Mullins, now Julio lived in San Antonio. Chuck was in Houston, so they knew it was a close distance. So he went up there to visit him and thought maybe he can use this in congenital heart disease. He reported this in 1988, and by the 1992, he reported the first human series of stents. And again, I think that was when pediatric interventions really blossomed, and it became the field that we all know now. Of course, the stents were under trial, but because became approved for biliary use, the FDA approved it for biliary use, the companies no longer wanted to spend money to do trials in congenital heart disease, because there's not too many cases, so the profits aren't that big. So they stopped the trials once it became approved. Of course, over the next 30 years, we all used it off-label. So to this day, in the US, there's not a single stent that is officially approved for congenital heart disease. So everything is done by off-label use. And I know that's a problem in many other countries as well, including Korea and a lot of the other Asian countries. Now, in 2007, the first trial started now using the CP stent for coarctation. The story behind that was that NewMed, who came up with the stent first, broke some FDA, had some violations. They were fined a lot of money. But during the trials, because it became clear that no company wanted to invest money in congenital heart disease, the FDA basically said, we will fine you this money, but you have to put it into a trial. So that's how the money came along. NewMed had to pay to do this trial. And I have to say that as of last year, 2015, the covered stent actually got approved. Now, it hasn't come out to market yet. It's going to come out this summer. But finally, we have a stent that is approved for congenital heart disease, and that's the covered stent. Let's go over some landmark angioplasty data. In 1990, Abe Rothman wrote this paper from Boston Children's looking at angioplasty in pulmonary arteries. Basically, it showed that there was a 58% immediate success. Not very high at the time, but that was the only thing that was available at the time. If you look down here, the vessel diameter went from 3.8 to 5.5, and they call that successful because that's more than 20% increase in size. The gradients dropped by 43 to 14, and the ratios went from 84 to 72. Now, 72 is still pretty high in my standards, but back then that was considered successful. 16% restenosis rate. This is interesting. If you look at that original paper, the criteria of success says if you increase the diameter by 50%, increase the flow by 20%, or decrease the right ventricle pressure ratio by 20%, that is successful. But I want to point out a very interesting word here, and that is the word arbitrary. In other words, there was no fancy scientific way to say this is the criteria of success. This is what the group decided in Boston, that this is an arbitrary decision, that this is what is successful. But you know what? Since then, every one of us, when we do papers on success, we use this as a reference. But I want everyone to know that this is arbitrary from the history books. Look at 135 patients here, average about 6.6 years. The vessel diameter increased from 3.8 to 5.5. So that is a big difference. But if you look at the newborn pulmonary artery, that's pretty much the normal size of a pulmonary arteries in a 6-year-old. So is that really successful by normal standards? By those criteria, yes, it was. So if you look at criteria for success, I always ask myself, what is it? The indications has to be based on what your goals for treatment is, right? So in angioplasty, if the results fall within the indications for treatment, is that procedure considered to be successful? I would say maybe not. So nowadays we use indications for an intervention for branch stenosis is elevated pressures by more than 2/3 compared to the arteries, significant gradient more than 20 millimeters in a good functioning heart, or any gradient in a single ventricle or poor function RV, or significant difference in flow, probably greater than less than 30 to 35% to the affected lungs. Now again, I always say that success, if you base it on arbitrary criteria, may not be good enough. So I just want to make sure you guys know that history, that this is arbitrary when you look at the criteria for success. So here are some of the landmark papers on stenting that Dr. Mullins and his group worked out. In 1988, he put stents in the dogs to show that you can do this in the vessels besides the coronaries. O'Loughlin, who was one of his trainees, wrote this paper in 91, basically concluding that stents can be used in post-operative stenosis in congenital heart disease. So that's the paper that probably gets referenced the most anytime we write a paper on stents, because that was what everything was based on afterwards. If you compare angioplasty to stenting, I looked at this for many papers, and I'll give you the sources if you want. Basically, angioplasty has a median success rate that ranges from anywhere from 53 to 72%, with a restenosis rate of 16 to 35%. But if you look at stent papers, it's anywhere from 95 to 100% immediate success, with a restenosis rate of 3 to 12%. The numbers are obvious. We know stents work better. So here's the original Palmol stent. It's made out of stainless steel, laser cut, and basically was the workhorse for congenital heart disease from 1980s to 2000. At that time, there was only one type of stent available. There was one for the medium-sized vessels up to about 8 to 10 millimeters. We call those the 4 series, like the 124, 184. Then the larger size go up to about 18 millimeters. We call them the 8 series, the 188, the 308, for example. And however, they had very sharp edges. They're very stiff. Here's some of the original pictures taken by Dr. Mullins when he did the dog model in 1998. You see how the stent looked like inside the pulmonary arteries here. The bottom part is filleted open. You see the stent that has been the endothelial tissue on the stent. Here's some microscopy looking at the stent struts and see how the healing process, the endothelium covers the metal. By 2000, another stent came along, the double strut. I remember when I first saw that, I said, wow, this could be a better option than the Palmaz stents. It was an open cell design. It allowed less foreshortening. It was much more flexible and had rounded edges, and it was excellent. However, you notice that it was started by a company, Therapeutics. It was sold to EB3, and it's sold to Covidien. So it's gone through several parent companies. This stent has been advanced to a newer Mega and Max LD stents, and I'll show you examples of that. See that the double strut stents have an open cell design that it can change in the cells so that you can maintain the length without foreshortening. So here's the Palmaz compared to the double strut, and then you see the CP stents. CP stents are made out of platinum iridium. It's welded, so it's not laser cut. I really don't think it's as good of a stent because of how it's produced, because fractures can occur at the welding sites. The Genesis stent came along in 2004, and to me, that is the workhorse of the current era. And it's again made out of stainless steel, it's laser cut. It's got these sigmoidal hinges, if you will, that can be flexible, very rounded edges, very low profile, very flexible. And so now this is the current era standard for stenting at this point. I think this is a much better stent than the CP stent for common use in the PA. So you see that the Palmaz stent here in 1986, the Genesis stent in 2001. Here's the double stent evolution that gone on to the Mega LD and compared to the double strut. Little stronger in strength, same open cell design. This came out in 2005. See how you can open up the sides and create a hold on the side. So you can balloon the side, so if you have jailed the vessel, a side branch, you can go through the side and balloon that. So just to show an example of a coarct where it's jailed the subclavian, you can balloon it there, and then you can you go right through the side and open up that side vessel. Here's the CT angio showing the side hole on the stent. Now, in 2009, the Vallejo stent came along. I don't know if that's available in Korea, but this is, to me, another new workhorse for me. The reason is because this is pre-mounted. You don't have to put them on. It goes through a 7 French system. It goes up to 9 to 10 millimeters, but this particular stent can be dilated up to 20 millimeters in diameter. Make sure you use the ones that are pre-mounted on 9 and 10, because the smaller ones will not go up to 20. They can only go up to like 12, 13. But this one can go through 7 French system. Again, you see how that when you serially dilate it, the side holes open up and you don't have much foreshortening. It can go up to 20 millimeters in diameter, which is a very good size for pulmonary arteries. So here's the example of the extra large stents now for the aorta and the outflow tracts. The Max LDs, the Palmaz XLs, and the CP8 Again, these go up to about 24, 25 millimeters. This came along in the late 1990s to 2000s. Of course, the covered stent came along, and now finally, as of last year, it became approved, not last year, last month. I said 2015 earlier, I meant 2016. We still don't have it in the hospitals yet, but we were told it was approved officially, and so we're very excited about having this in our package in our Cath lab. So here's an example. I got this from Dr. Rangel, showing an aneurysm that you can cover with a covered stent. So here's just going back to history. 1985, this was an 18-month-old patient with severe stenosis. I got these pictures from Dr. Mullins. You notice back in those days, the contrast is white. Now, using digital, the contrast is dark. So here you see how it's dark now. 22 years later, the stent is still wide open. So stents have had long history of good use. So we know that this is very effective in the long run. Let's look at ASDs. Again, I don't have to talk a lot about ASDs because you guys are very familiar with that. But let's go over the history. It's 1975, Dr. Mills came up with his device, 26 French system, huge system. But he reported this in 1976. Here's Dr. King, here's Dr. Mullins. I'm sitting in the back. See how much bigger they are? They're giants of the field here compared to me. Rashkin has the hook ASD device in 1977. See these little hooks here? They basically hook onto the septum. The good thing is that it can keep it very secure. The bad thing is that if you're in the wrong place, you can't easily remove it. So that becomes a problem. It went through a 12 French delivery system here. The clamshell came along in 1989 to 91. You see there's a double disc system. There's a stainless steel with hinge point here, goes to an 11 French system. When I was training at that time, we used a lot of these for ASDs. Sedaris button, again, 2-disc system, 1990. It looks like styrofoam, and it becomes very, it dissolves over time. But here, the clamshell became the Starflex because they added a second hinge because of fractures. This gives a little more flexibility to prevent fractures. The Angel Wing, I don't know if you remember that, but this was a double disc system that had a self-centering system where the center was sewn into a disc also so that it's self-centered. That was a great idea, except these corners caused a lot of erosion, so that was taken off the market. So here's the evolution of the ASD devices, many different devices that developed. I remember in the 1990s, every time I went to a conference, there'll be another company with a new idea of how to close an ASD. But all of these are extinct now. Why? Because the Amplatzer came along, and this again became the big workhorse. So much so that there are a lot of other companies that make similar devices in many countries. And again, very useful, very, very good. ASD, so the Amplatzer device became available in 2001, FDA approved. The Cribiform device came out in 2006. The Helix device made by Gore became approved in 2006. I don't know if that's available in Korea or in many Asian countries, but just to show it to you, basically it's a nitinol helix that has a Gore-Tex sewn around it. And once you open up the left disc, you pull it together, bring it against the septum, pull back, and basically push out the right disc, and basically you created that closure with the device. The current status is that all these are available, and in fact, in 2015, the Helix device has now evolved to the cardioform that looks like much more easy to deliver. Unfortunately, I don't have a picture for you this time. So the current status is that ASD is 95% or greater closure rate with very little complications, but they do include some arrhythmias, device embolization, some thrombus formation, and some erosions. VSDs came along, closures for VSD, and you'll see that the first report actually took place in 1988 by Jim Locke. In fact, some of the devices were used in the VSDs. Interesting that the only device available for VSD up into the Amplatzer was the the clamshell device. Subsequently, the muscular device from the AGA has become available, and that's what we use the most now. The data that came out from Rolf Halser in 2004 showed that this is what was the data that was used to get the FDA approval. Again, excellent results. Just a quick example, this is on a very small kid, 4.5 kilo baby with a pretty good size VSD. Put the sheath in from the IJ, deliver the left disc, bring it against the septum, deliver the right disc, and you release it after you're happy with it, and you take your picture. So you guys are very familiar with that. You see the picture of again, you can go down to very small kids. Let's talk about the transcatheter valves. In 2000, Bonhoeffer came up with the idea and implanted the first one in France in 2000. By 2006, it already got an approval. So in 6 years, the various trials resulted in approval in Europe. And by 10 years, it became approved in the United States. So again, in 10-year period, we've gone from concept to general use in the country, in the US. This is the paper from McElhenney that led to the result of the FDA approval, showing a 94% freedom from intervention and malfunction in 1 year. So excellent success. You don't need to, you guys are a little bit familiar with it already. If you look at the congenital heart disease and RVOT anomalies, about 20% of patients have outflow tract anomalies. If you look at that, you find that about 15% of these will end up needing a conduit that will need to be changed out. So again, there's going to be a huge number of these patients, and especially in post-op situations where you will need to implant the valve. I'm sure that with new inventions and new technology, you're going to start putting valves into native outflow tracts as well. So you guys are a little bit familiar with the pulmonary valve. It's made out of the bovine jugular vein with the valve there sewn onto a CP stent. This is what it looks like, and it delivers through a 22 French system. This is in the pulmonary valve, but you know that in the last few years, it's gone into the tricuspid valve as well. So here's an example of the tricuspid valve. You see the pulmonary melody valve in the pulmonary position. Here's the pulmonary melody valve in the tricuspid position. And using some hybrid techniques, you can even put them in the melody valve. I think I actually presented this at the meeting a few months ago here. So you see that using hybrid technique, we've been able to actually put the melody valve in the mitral position as well for some of the kids with severe AV mitral regurgitation. So how far have we come? We've improved the cardiac cath lab in terms of the machinery. We lowered the radiation. We've improved the angulation, the flat panel technology. We have 3D rotational angiography. We have all the extra help from echo, MRI. We have a lot of ancillary imaging using TE and IVUS and ICE and CT and MRI to help us in the interventions. We have many established procedures now, right? We're now putting valves in all four of the in its positions, especially in the adult world with the aorta. All the different vascular stenoses, the pulmonary veins and arteries, the systemic veins and arteries, we can do angioplasty and stent. We put stents in, stents to permanently support vessels. We can even open totally occluded vessels, as well as the atrial septum using various transeptal techniques. We have transcatheter pulmonary valves, and we've put them in the other valves as well. We've closed all kinds of septal defects and abnormal cardiovascular communications. We've gone a far way. So I think that the cardiac cath lab for treating in the future, we have to aim far, and we have to reach far and aim high. So this is a clip that we got from this is from a German engineer. So this is what we're doing right now in congenital heart disease. Thank you for your attention. I know it's late in the day.